Hayalperestlerin, risk alanların, denemekten korkmayanların cesaretinden doğduk. Bizi asla yarı yolda bırakmayan o sesin rehberliğiyle ilerlemeye ve öğrenmeye devam ediyoruz. Bunun için varız. Bu yüzden gece geç saatlere kadar lambalarımız sönmez. Elveda demek hem hüzün hem de gurur verir. Her şeyi sorgulayarak ve merakımızı besleyerek, dayanıklılığımızı test ederek, sınırlarımızı aşarak, ilerleyerek ve yeni ufuklar açarak yeni bir yol buluruz. Yeni icatlar çıkararak, kendi yolumuzu çizerek. Burası fikirlerin doğduğu ve yeni fikirleri doğurduğu, bizim de doğduğumuz, birlikte büyüdüğümüz ve yükseldiğimiz yer. Burası Yakın Doğu Üniversitesi.
Okay, dear participants, I am opening the first session of this afternoon. I am honored to chair this session with Dr. Meltem Nalçı Andrew. Dr. Nail will not be with us due to a mandatory program change. Our first topic will be review of hospital use of ionization radiation in radiology, and this topic will be presented by Dr. Sinem. Before inviting Dr. Sinem, I would like to introduce her briefly. Dr. Sinem Şıht İkiz was born in Izmir in 1985. She has graduated from Samsun 19 Mayıs University, Faculty of Medicine in 2009. She completed her training in radiology at Ankara Atatürk Training and Research Hospital in 2017. Dr. Sinem attended European Society of Radiology Fellowship Program at the Department of Radiology Breast Cancer Unit in Vall d'Hebron University Hospital, Barcelona, Spain in 2020. Dr. Sinem is currently working at Near East University Department of Radiology since 2018, and breast imaging, thoracic imaging, and emergency imaging are main interested areas of Dr. Sinem. Dr. Sinem, you have the word. Thank you.
Thank you, dear Chairman. I would like to talk about review of hospital use of ionizing radiation in radiology today. So, the utilization of radiation in medicine for diagnosis and treatment dates from the 19th century, almost from the time X-rays and radioactivity were discovered. In 1895, a German engineer, Wilhelm Röntgen, figured out how to produce and detect electromagnetic energy in a particular wavelength range that came to be known as X-rays. Within a year, people across the world were fascinated by the new ability to look at their own hands, stripped of flesh with rings clearly visible around skeletal fingers. Now its use is deeply embedded in medical practice. For many purposes, it is indispensable both for diagnosis and for treatment. Here I wanted to show you this electromagnetic spectrum. X-ray is here, as you can see. The electromagnetic spectrum is a wide range. It's a range of frequencies and electromagnetic radiation, frequencies of electromagnetic radiation and their respective wavelengths, as you can see here, shorter and longer wavelengths, and photon energies. Extreme ultraviolets, soft X-rays, and hard X-rays and gamma rays are classified as ionizing radiation because their photons have enough energy to ionize atoms, causing chemical reactions. While I was getting prepared for this topic, I found this diagram made by...
Sinem,
Yes?
excuse me. Could you share your presentation, because we lost your presentation?
It's on the...
No
Okay,
worries.
let me
We
show you.
can wait for you. Okay.
Okay, thank you. Sorry. Is it okay now?
Yes, but it is better to present before the beginning, actually.
Yeah, okay. Okay. Sorry for the delay again. I will talk about the review of hospital use of ionizing radiation in radiology today. I have mentioned that in 1895, a German engineer, Wilhelm Röntgen, figured out how to produce and detect electromagnetic energy in a particular wavelength that came to be known as X-rays. And within a year, people across the world were fascinated by this new ability to look at their own hands and skeletal fingers. And now the utilization of radiation is have been used from dates from the 19th century. And now its use is deeply embedded in medical practice for many purposes, both for diagnosis and treatment. And I wanted to mention about the electromagnetic spectrum, which is the range of frequencies and electromagnetic radiation, frequencies of electromagnetic radiation, and their the respective wavelengths, which you can see here, the shorter wavelength and the longer wavelength, and photon energies. Soft X-rays, as you can see here, hard X-rays and gamma rays are classified as ionizing radiation because their photons have energy to ionize atoms, causing chemical reactions. While getting prepared for this topic, I found this example, radiation dose example, which is made by the Canadian Nuclear Safety Commission. As you can see here, we get radiation while we typically cross Canada by plane. So we have radiation in all our lives, but the medical use is important today for us. So we will talk about the detail now. So there are three distinct fields in hospital use of ionizing radiation. I will only figure they mainly because we will talk detail with the other participants later. So in radiology, more than 90% of the radiologic procedures are diagnostic, and we use X-ray in these procedures. As well as this, we use radiation in nuclear medicine and in radiotherapy too. So my main topic in radiology. What do we use ionizing radiation in which modalities? I mainly divided into some groups. We will talk about radiography, we will talk about fluoroscopy, computed tomography, and interventional procedures today. So, radiography, our first one. X-ray or radiography uses a very small dose of ionizing radiation to produce image of the body's internal structures. X-ray, which is a radiography, is the oldest and most frequently used imaging modality in our daily lives. During this procedure, an X-ray beam, as you can see here, X-ray generator, X-ray beam is passed through the body from the generator, and a portion of X-rays are absorbed or secured by the internal structure, and the remaining X-ray pattern is transmitted to a detector, as you can see here, so that an image may be recorded for the later evaluation. And this is a diagram of a stationary anode X-ray tube, which is inside this device. And it's composed of a glass envelope, which is outside, a cathode, and an anode, and filament, and tungsten target here, and a copper anode. This is basically, I didn't want to talk very detailed, but it's basically composed of this. So we have conventional radiography, and digital radiography. In conventional radiography, which you can see here, mentioned as analog images, the spatial position and the film density are analog values. But in digital radiography, we use matrix to present an image. So what's matrix? A matrix is a square area. You can see here a square area divided into rows and columns. And the smallest element of a matrix is called pixel. So each pixel of the matrix is used to store the individual gray levels of an image, which are represented by numbers, as you can see here. And the location of each pixel here in a matrix is encoded by its row and column number with X and Y axis. Conventional radiography is limited to imposition of a 3D subject onto a 2D plane. So we don't see here, as you figured out, we don't see the differences between water or brain soft tissue. I mean, water as the other parts. We can't differ the parts from the radiography, so we will need to do more complex modalities, which we will talk about later. So now our other modality which we use ionizing radiation was fluoroscopy. Fluoroscopy is a medical procedure that makes a real-time video of the movements inside a part of the body by passing X-ray through the body over a period of time. So we have a real-time video, we have movements, and we have a period of time. So in this modality, the X-ray is transmitted through the patient, and radiologists can watch the images alive on TV monitor, and we can record the images also. So we use mostly in observing the digestive tract and with barium contrast agent. And we can also store the images. We can also we have a photographic plate replaced by the fluorescent screen, and we can use a television camera to watch it and record it. And our other modality is mammography. Mammography is a specialized medical imaging method that uses a low-dose X-ray system to see inside the breast tissue, detailed breast tissue. A mammography exam, which is called a mammogram, aids importantly in the early detection of breast cancers and the diagnosis of breast cancers in women and both men. X-ray mammography is the most reliable method to detect the breast cancer. It's still the most reliable method that we use. And it's the method of choice for breast screening programs in many developed countries. Here I wanted to show you a mammography device. And inside this part, here we can see the X-ray tube, a device for compressing. It's a compression bed pedal. And here we can see the anti-scatter grid and the detector, the receptor, and we have an automatic exposure control system for lowering the dose of radiation according to the breast, and it's very useful. Here again, the device, and here you can see the patient and the breast between the compression pedal and the grid, where we give some position to the patient and the breast, and we use compression method, and then we get the results, the images. So, and during a mammogram, the patient's breast is placed on a flat support plate, as you can see here, and it's compressed with a parallel plate which we call compression pedal. And the X-ray machine produces, here the X-ray machine, it produces a small burst of X-rays, and this passes through the breast, and the detector located in the opposite side detects the X-ray, and then it captures the X-ray image on the film and transmits the electronic signals to a computer, and we at last have a digital image, which is called mammograms. The most important thing that with the mammography is that we use lower doses, and we use special anode filters for lowering the doses, because we take annual screens for the breast screening programs. The other topic is computed tomography. It's the CT provides the improved low of contrast resolution for better visualization. We have slice technology, and here we use the CT uses an X-ray tube. Here you can see the X-ray tube, and it's a detector here. And the image is a simple array of X-ray densities, and there are many hundreds of these that are used to make CT image, which is a slice through the patient. Here you can see the slices and the CT images of the patient. We use mathematical technique called filtered black projection in the CT technique. I would like to show you a 2 minutes video to understand how CT works better. So just can you see the video? I will start it now. Here you can see the X-ray source, and the other here is the detector. When this X-ray source is switched on, it will start releasing X-rays, and the detectors here will detect it. And every slice that it goes through, there is a data and data information, the data density values that is summed in the computer and changes to mathematical techniques. Here you can see the turning. Actually, the patient moves, not the detectors. When the patient moves, there is a data and it's summed in a computer, and it's with a special mathematical technique, every number has a specific density. Here you can see the open CT view image here. It turns and the patient goes through it and out, and it takes only 30 seconds to examine, almost 30 or 40 seconds to examine all the patients in one way. So now again, I will continue with my slides. And here are the examples for the CT images that we look here for the neuroradiology, and for abdominal imaging, we check the abdominal organs. And also we can have reconstruction images, and we can see detailed structures as 3D projections. And our other modality is bone mineral densitometry. It's a test, measures how much calcium and other types of minerals are in an area of your bone. And it helps your healthcare provider to detect osteoporosis and predict your risk for bone fractures. And we use this T-score to identify, to talk about the bone structure. and say osteopenia or osteoporosis. And the other usage of ionizing radiation is the vascular and interventional radiography, which is another subspecialty in radiology and that are performed with X-ray using image intensifiers and or flat panel detectors. Interventional radiology comprises fluoroscopy, guided therapeutic and diagnostic techniques. These are complex procedures and they require specially designed equipment and result in high exposures to both the healthcare product provider and the patient. So it's important to have a good knowledge of equipment specification and characteristics in order to give an effective radiation protection. And the interventional radiology procedures may be classified into cardiac, non-cardiac, and vascular and non-vascular. Vascular procedures are embolization, drug infusion, angioplasty, and transjugular intrahepatic portosystemic shunt, which we call TIPS, or non-vascular procedures, which are drainage and puncture and percutaneous needle biopsy and coagulation therapy. And I wanted to mention in my talk that about the radiation doses of common medical procedures. I want especially to look at chest CT here. It's 8 millisievert, but plain films, which are radiography, X-ray procedures, it's the CT images. As you can see, they are 100 times more than the radiographies. And here you can see the abdomen and pelvis, which is 10 millisieverts. So it's 100 times more. So it's better to be careful with the choices that we make while examining our patients. And for this, I want to mention the justification and optimization. Justification is the imaging procedure should be judged to do more good than harm. So we want to have the benefits. We don't want to harm the patient. Therefore, all examinations using radiation should be performed only when necessary to answer a medical question or treat a disease or guide a procedure. We should have a reason to do it, and we should know or expect our results. For the optimization, X-ray examinations should use techniques that are adjusted to administer the lowest radiation dose. Here, I also want to mention about ALARA. ALARA is a technique factor as low as reasonably achievable. So the clinical indication and the patient medical history should be carefully considered before referring a patient for any ionizing radiation examination. And ALARA is a technique factor that the technique factors should be chosen based on the clinical indication, like the patient size and the anatomical area which we will scan and the equipment. It should be all properly maintained and tested. ALARA stands for as low as reasonably achievable. It means avoiding exposure to radiation that does not have direct benefit to you, even if the dose is small. To do this, we can use 3 basic protective measures in radiation safety, which are time, distance, and shielding. And if such information can be obtained timely and accurately from other tests with lower radiation dose, like plain radiograph, or no ionizing radiation doses, which are like MRI, ultrasound, then it's not appropriate to perform a CT scan. So the most important step in building a dose conscious CT practice is making sure that all the CT examinations are performed for justified or appropriate for clinical reasons. So what can we do? We can avoid duplicating the exam. We can record the patient's ionizing radiation-based exams. We can use the guidelines and sources that helps us to have the exam or not. Or we can use several softwares which we generally have our CT systems, like for the pediatric patients, to lower the dose. And we can also avoid unnecessary CT. We can also, by avoiding, we can have the reduction cost. We can have the anxiety reduced because the patient doesn't have anymore if we don't have the CT. And also, if we don't have the CT procedure, that means we will avoid the contrast media's related side effects. It has many advantages. And what can we use for the appropriateness sources? We can use some criteria or guidelines as American College of Radiology or European Commission referral guidelines, or the guidelines by Royal College of Radiologists. But I want to show you a very quick system. It's a decision report system, and you can reach from the internet. You open here is an example for the head CT. You can open the page, the website, and you can see the protocols here, which use contrast. If you need contrast, the patient infos, which is you can see here, is the creatinine and urea and the films. Then you enter the patient's symptoms here. You will choose one of them, and you have to choose, or if there is, you have to enter the known diagnosis. And then there is a utility color and utility score here. And if it's red, it's low utility. If it is yellow, it's intermediate. And if it's green, it's high utility. And we complete it in online. Then it says the decision. The feedback screen comes, and the decision here says it's 3. It's low utility. It means the benefit of the screening is lower. So of course it's your choice to do this to the patient, but according to this support system, then your head CT is not appropriate for this patient. I know about the malpractice problems nowadays, but we have to be careful with the ALARA too. So our main principle is to protect our patients. So it's better to decide very detailed. Or if you don't use this system, you can ask yourself 5 questions, like, has it been done already? Do I need it? Do I need it now? Is this the best examination? Have I explained the clinical problem? With these questions, I believe that we will help our patients more. Thank you for listening to me.
Okay, thank you. Thank you, Dr. Sinem. Sinem, if there is any question from the audiences, we can get the question to ask Dr. Sinem. Okay, Sinem, there is a comment from Dr. Doğanbor, and I would like to forward this comment. You said mammography is not a low-dose technique. Actually, due to use of very low X-ray energies and sensitivity of the breast composition to radiation, although it is a common modality and low energy, but it is more easily absorbed. So we should be careful to use mammography, and we have to schedule mammography exams according to the age of the patients.
Yes,
So
our parameters. Sorry. Our parameters are different from the other X-rays, the other radiographies. I wanted to mention about it. I didn't talk detailedly, but I tried to talk about it. We use different parameters to lower the dose. Okay.
Okay.
Thank you, Dr. Doğanbor, for your comments.
Okay. If there is a question, still we can get the question to ask Dr. Sinem or any other comment. Okay, then let's move forward to the second topic. The second topic will be the review of hospital use of ionizing radiation in nuclear medicine. And this topic will be presented by Dr. Hülya Efetürk. I would like to introduce her briefly before starting her speech. Dr. Hülya Efetürk is graduated from Hacettepe University, Faculty of Medicine in 2010. She completed training in nuclear medicine at Ankara Oncology Training and Research Hospital in 2016. And she has been a visiting doctor at the Department of Nuclear Medicine in University Genoa San Martino Hospital in Italy. Also another university hospital in Augsburg, Germany, and University Hospital Würzburg. And she completed obligatory working services at Dr. Burhan Nalbantoğlu State Hospital between 2018 and 2020. Dr. Hülya is currently working at Near East University Department of Nuclear Medicine since September 2020. She is my colleague. So, Hülya, the word is yours.
Thank you, Dr. Nuri, for your nice presenting. I would like to present the review of hospital use of ionizing radiation in nuclear medicine. First of all, I would like to explain what nuclear medicine is, as most people around me, even my close friends, don't actually know what my job is and what I do. People I've known for years tell me, "Oh, you're a radiologist, aren't you?" And I tell them, "No, I'm not a radiologist. I'm a nuclear medicine specialist." Nuclear medicine, the definition is that it is an imaging modality, both imaging and therapeutic modality, that with the administration into the body of small and safe amounts of radioactive materials are used to see how organs or tissue are functioning, which is used for diagnosis, or to target and destroy damaged or diseased organs or tissue, which is used for treatment. So we give diagnostic information and help the clinicians by staging of the disease, giving therapy, tailoring therapy for patients, and monitoring the response of a disease process. It uses the principle of using radioactive isotopes, which are linked to specific molecules, and they are called radiopharmaceuticals, and the radioactive isotopes are called radiotracers. In most of our imaging modalities in nuclear medicine, a very low activity is used. We also use the ALARA principle, but in therapeutic cases, we use a much higher radiation dose. The dosage we give to the patient is determined by the patient's body weight and by the reason of the study and the body part being imaged. The radiopharmaceutical that is being used targets a specific organ of interest and is delivered to the specific organ of interest while not giving a high radiation dose to the rest of the body parts. In our department, we use alpha particles, beta particles, and gamma rays, which are ionizing radiations from the electromagnetic spectrum, which I'm sure you are all familiar about. Alpha particles and beta particles are used in therapy. They are not used in imaging, whereas gamma rays are used in imaging. They're used in diagnostic purposes. And after the radioactive substance emitting these radioactive waves are administered into the body, gamma rays can travel for meters. And that is how the radiation coming from inside within the body reaches the nuclear medicine instrument, which detects the radiation and then turns it into an image. But alpha particles and beta particles cannot travel a long way. After entering the human body, they cannot travel a long way, and that is why they are not used for imaging. They are used in therapy because they are very highly energetic particles and they deposit a lot of energy, hence destroying the target. Here is another similar example to how far alpha particles can travel if an accident happened and it dropped onto the skin of a patient by accident. Alpha particles cannot penetrate the outer layer of the skin, so they are not very harmful if they come from outside of a body, but from internally, it's the opposite. It causes high density ionization within the tissues, providing concentrated energy, and this damages the DNA and has strong biological effects. And that's why we use alpha particles in therapy. Beta particles also have an effect, similar effect, but are much weaker. Beta particles can pass the epidermis of our skin, so in an accident, it would have a deterministic effect on our skin. Gamma rays, like I said before, can travel a long way, but do not have high ionization density. This is a classification of radioactive isotopes that are in use. And the main radioactive isotopes that we use in nuclear medicine on a daily basis are in class D, which is low radiotoxicity, technetium, metastable technetium 99, and F18, which is in class C, which has a medium level of radiotoxicity. Like I said, we use radioactive substances that are given into the body. What are these radioactive substances? They are called radiopharmaceuticals. We attach the radioactive part, which is the radionuclide, to a ligand. A ligand is the non-radioactive part, and it just carries it to the target organ. It carries it to the target organ, and then we name it as a pharmaceutical drug containing the radioactive isotope. Radiopharmaceuticals can be used for diagnosis and therapeutic agents. How are these radionuclides that we use in nuclear medicine generated? Where do they come from? Some of them, and most of them, are produced in nuclear reactors. Some are produced in generators, and some are produced in cyclotrons. Radionuclide generator systems, they contain a parent radionuclide which decays to produce the radioactive daughter. The parent is usually produced in a nuclear reactor. We most frequently, the one that is used all over the world on a daily basis to millions of patients is the molybdenum technetium generator, and it produces technetium. And another example for a radionuclide generator system is the germanium gallium-68 generator, which produces the daughter, radioactive daughter gallium-68. Here I would like to add that the parent radionuclides have a very long half-life, whereas the daughters have a shorter half-life. Once we inject a patient with a radioactive substance, we don't want that patient to be radioactive for weeks or years, do we? We need the patient to have a scan done or have a therapy done and then have it eliminated from the body. So the patient doesn't have the effect of ionizing radiation in their body for too long, and they don't emit radiation to the public either. So that's a very important characteristic of daughter radionuclides, is that they have a much shorter half-life when compared to their mothers. Reactor products, these are examples to reactor products which we use in our department quite frequently. Molybdenum is the mother of technetium. Cyclotron products, F18 is the one that we use most frequently, actually on a daily basis. We have hundreds of patients every month. It's a positron emitting radionuclide, and we use it mainly in oncology patients, which I'm going to mention later on. Like I said, there are many agents we use in imaging, and technetium is the main one. F18 FDG is another main imaging agent that we use. And these gallium-68, PSMA, dotatate, and FePi are the other ones that we use in our clinic. I'm giving you examples from what we do in our clinic because there are so many diagnostic imaging procedures that can be done in nuclear medicine all over the world. It's impossible to mention every single one of them. There are tens, maybe over 100 diagnostic tests, scans that can be done. So I would like to mention the ones that we do in our department on a daily basis. Here is just a short example, visual example of all the tests that can be done, like evaluating the function of the kidneys, the thyroid, brain studies, the function of the heart, liver and spleen imaging, the bone scintigraphy. We have, like I said, loads of tests that we do, imaging and functional imaging. The main radionuclides and radiopharmaceuticals used in our clinic for therapy are iodine, lutetium, yttrium-90, and actinium-225. Iodine has been used for over 8 decades for the therapy of thyroid cancer and benign thyroid diseases. It has a medium energy of gamma rays and beta particles. The beta particles are used for therapy, and it has the gamma rays we use to image the patient after we give the therapy. It is used for diagnostic and therapeutic processes. Lutetium is used in the therapy of prostate cancer and neuroendocrine tumors. I'm going to give more detailed information on this. What are our scanners called? What do they look like? We have a gamma camera we use as scintigraphic imaging scanner. It has a SPECT component to it. Gamma cameras give us information, 2D information. It has 2 detectors, so it gives us collects radioactivity from the patient in 2 angles, anterior, posterior, or laterally. And with the SPECT component, it can turn around the patient and collect information from 360 degrees. Nowadays, the developed scanners have a CT component integrated into it, and SPECT images and CT images are fused together to give us anatomical information as well as the scintigraphic information. The CT component gives us more precise anatomical detail, which contributes to the patient's evaluation. Here we see a PET CT. PET MRI device has also been put into use, which has been given us the chance to give more detailed information, more precise anatomical information about the patient's illness. 1 minute. Hybrid imaging systems is the combination of nuclear medicine and radiology scanners. It gives us information about the anatomy and function. I'm going to have to speed up because time is ticking. These are examples for hybrid imaging. Here we see the nuclear medicine. This is an example from the PET CT. So here we see the FDG image. Here we see the CT, and here is the fusion of the image. Here, this patient on the CT, it was prescribed as atelectasis, but here we can see the function of the uptake of FDG is very high, very intense, and we can see that it is actually a tumor. So, step by step, the patient comes. You have to question the patient, why the patient has come, ask detailed information, make sure the patient hasn't had the same scan done a week before, because sometimes clinicians don't see the results and send the patients again. So you have to talk with the patient when they come. The nurse injects the patient with the radioactive material. Then the agent goes to this is just an example, the lungs, but whatever the organ that will be evaluated, it goes to the organ, and then the patient is imaged with the PET scanner or gamma camera, and then an image is generated, which is then evaluated by the nuclear medicine specialist. I don't want to confuse the listeners. Radioactive materials aren't only injected, they are also can be inhaled. Radioactive materials can be swallowed as capsules. They can be delivered to the organ the body in many different ways. I'd like to talk about diagnostics in nuclear medicine since it is very important. It uses the coupling of diagnostic and therapeutic tools related to the same specific molecular agents. And this enables us to select the correct patient for the correct therapy. I would like to show it like this. So this is the diagnostic application. This is therapy. It uses the same target. The one radiopharmaceutical carries it to the target, and we evaluate the patient diagnostically, and then in turn we use the same target and the same carrier with a different radionuclide, which then is used for therapy. And this is called the principle of diagnostics. Here you can see the radioisotope, the same specific molecule in common. This is used for imaging with the same molecule, and then the therapy is given with a radioisotope. I'd like to explain this a bit more in detail with images. This is a thyroid cancer patient given radioactive iodine with iodine 123. The imaging was done of a patient. Here we can see the metastatic lymph nodes or residual disease. And then therapy was given to the patient. This is post-therapy image, and we can see uptake in the same localization. Another example for diagnostic agents are bone-seeking therapeutic radiopharmaceuticals. First, the patient is imaged. We have detect the tumor. This is metastasis in a breast cancer patient. We can see the metastasis in the vertebra. And then samarium EDTMP is given to the patient for treatment, and we can see the uptake in the same spot. The imaging was done with technetium, and the therapy was given to the patient, samarium, but you cannot give the therapy directly. First, you must see that there is the presence of the tumor there, and it's uptake by technetium. Somatostatin analog radioligands is an example for modern diagnostic agents. The ones previously spoken about were classic diagnostic agents used for many years. We select the most appropriate patients that can benefit from the therapy we give in nuclear medicine to patients if they express this receptor, SSTR, somatostatin receptor, in well-differentiated or moderately differentiated neuroendocrine tumors, then we can in turn give the therapy. This is an example. In the image A, we can see we did a PET CT scan to the patient with gallium-68 dotatate, and here in the liver you can see the metastatic lesions. It's a pancreatic NET patient with hepatic metastasis. It shows intense somatostatin receptor expression. Because there was an uptake of the somatostatin receptor, the gallium-68 dotatate uptake, we said yes. We have seen the uptake in the lesions, then that means that this patient can benefit from lutetium-177 dotatate. And you can see this is the first cycle, second cycle, third cycle, and by the fourth cycle, you can see the response to the therapy. And here is an MRI image. You can see that the lesion has diminished. This is one of the most frequent therapies we give in our own department. Prostate cancer is one of the most common cancers we've seen in men. The prognosis is poor with metastatic disease, and the therapy we are currently giving in nuclear medicine has become hope for a lot of men. we have nuclear medicine has improved their quality of life with this therapy. What do we give? We can give, after imaging with gallium-68, with gallium-68 PSMA. PSMA is specific for the prostate cancer, but it can be taken up by other lesions, other tumors, or other benign situations. But it is very effective. It has a very high sensitivity and specificity in showing the primary tumor or relapse. Targeted radioligand therapy with lutetium or actinium is given to patients who show high uptake of gallium-68 PSMA. Hence, we select patients who will benefit from this therapy by selecting patients with a positive PSMA PET-CT scan. Here you can see metastatic disease all throughout the body. The PSA level is 246. And this is the image of a gallium-68 PSMA PET-CT after 2 cycles of actinium PSMA. As you can see, the carrier is the same as in the imaging. It carries the radioactive material to the metastatic disease sites, and you can see that the PSA level is lowered from 246 to 0.75, which means that the patient is benefiting from the radioactive therapy. Another one done in our department by Dr. Nouri is hepatic radioembolization. It's a multi-step, multidisciplinary theragnostic procedure done on primary or metastatic liver lesions. It is given in the form of microspheres. It's delivered to the tumors by angiography. Like I said, it's a multidisciplinary team is necessary for this. There are many steps to delivering the radioactivity to the patient selectively through the arteries of the liver to the tumor. Before giving the radioactive microspheres, how do we know that the patient will benefit from it? How do we know about the anatomy of the liver vascular structure? First, we give technetium macroaggregate albumin. We take the scan of the image of the patient before we give the therapy, which is a preparation for the therapy. And we know after doing the scan and necessary calculations are done, we know how the patient will benefit from the procedure. F18 FDG PET-CT, I'm sure that all of you know about. It is a lifesaver. It has revolutionized the diagnosis and management of various types of cancer, inflammatory and infectious conditions, neurologic and rheumatological diseases. I'm not going to give much information about this since my time is nearly up. But I would like to add that in these the theranostic agents that I've just talked about, if sometimes we have to do an FDG PET-CT scan because tumors, the differentiation of the tumors change. The more de-differentiated the tumors become, the more aggressive they become, and that is when FDG PET becomes positive, and that is when we know that the patient may not benefit from the therapy, which saves the patient from unnecessary therapies. Dosimetry is something that is, it uses the system of estimating the absorbed radiation dose. It's tailored for every patient. So estimate how much radiation dose the patient will benefit from to give the minimum dose and reach the maximum effect, maximum therapeutic effect with the minimum toxicity. So dosimetric studies have helped us achieve a less toxicity and reaching the same level of therapeutic response for patients. Nuclear medicine examinations are quite safe, but radiation is radiation. So before injecting the patient with anything, you have to justify the procedure. Just like Dr. Sinem said, the test must be justified. You must know why you're doing something, what kind of information you want to get from that scan. Here I'm coming to the end. I only have a few slides I'd like to show you. Here you can see that the annual dose per person, radiation exposure to a person is 6.2 millisieverts per year. One chest, one X-ray film will give you 0.1 millisieverts, and one PET-CT study is less than 14, it's between 10 to 14 millisieverts. And this is just for comparison. Radiation exposure of patients and personnel from a PET-CT procedure with 8F18FDG. The total effective dose to the patient from a PET-CT procedure is approximately 10 millisieverts. The major part comes from the internal irradiation due to radiopharmaceuticals within the patient, which is approximately 6 to 7 millisievert, and a minor part is due to the CT scan, which is a low-dose CT scan we use for the patient. There is something I haven't highlighted here but would like to mention. If the patient is pregnant, a PET-CT procedure should be avoided or postponed if a patient is pregnant, unless it is vital for the patient. So in the case of pregnancy, we always prefer not to use radiation, but if it is vital, if the patient will benefit from it on a much larger scale, then these procedures are done. Interruption in breastfeeding is not necessary after a PET-CT procedure of a nursing mother. Only minimize the time spent with the child. Only avoid it for a couple of hours, since the washout from the body doesn't last long due to the short half-life. And yes, putting risk in context. This is the risk assessment of lifetime fatal risk from everyday activities. So having an accident while riding in a car, you can see that the lifetime risk is 304. And getting cancer from a bone scan, you can see how much lower it is. It's even, you're at a higher risk of dying from choking, or having an accident crossing the road is much higher than you getting cancer from a PET scan or from a bone scan. This is the last thing I would like to say. We work as a team. There is a nuclear medicine specialist, nuclear medicine technologist, nursing staff, nuclear medicine physicists and pharmacists, which we all work together in a nuclear medicine department. If one person makes one mistake, then it's like dominoes, they stumble down. So we are all connected together, and I would like to thank my team. And that's it. Thank you for listening.
Thank you very much, Julia. You give a very clear, brief, and explanatory presentation, and you told us what nuclear medicine special does and what nuclear medicine is. Thank you again. If there's any question from the audiences, I can forward to you. Or any comments. Okay, I think I am done. Thank you, Julia.
Thank you.
So hello again to everybody. As Professor Nail Bulakbaşı was obliged to be abroad, I took his place. So I'm very happy, in fact, to announce my dear friend Yavuz Anacak. But first, I want to give a short information about him. He is a professor of radiation oncology at Ege University in Izmir. His main clinical and scientific research includes management of pediatric cancers, sarcomas, central nervous system tumors, lymphomas, brachytherapy applications, and also nationwide planning for radiotherapy infrastructure and strategies to enhance radiotherapy capacity in low and middle income countries. He is the past president of the Turkish Society for Radiation Oncology. He was the head of the Radiation Oncology Department and deputy director of the Ege University Hospital, worked at the International Atomic Energy Agency as a consultant, and collaborated with the International Atomic Energy for several research and educational projects and missions worldwide. Professor Anacak is a member of the ÖSTRO International Society for Pediatric Oncology, Pediatric Radiation Oncology Society, and Turkish Pediatric Oncology Society. And I have to say that he is very valuable in our Radiation Oncology Society. So I'm very happy to introduce Dr. Anacak, please. And your microphone is closed.
Thank you, Meltem, for very nice, very kind introduction. I'm happy to be with you today. Ladies and gentlemen, in the next half hour, I will explain what is radiotherapy, what is radiation oncology, what we are doing in our discipline using ionizing radiation. Okay. So radiotherapy is the treatment using ionizing radiation. The energy, when high level of energy hits to an atom and it's capable of throwing an electron from the atom, then an ion is formed. So this is ionizing radiation. So to do this, there should be a very high amount of energy, so it is capable to throw electron, eject electron out of the atom. So there are several types of atoms. There are several types of particles can do this: alpha particles, beta particles, gamma energy, and neutrons, and all starts and a cascade of events and interactions inside the atom. So we use at the end of these interactions, there are several actions started inside the media, and here when this energy hits to a human body, so these events start inside the body. So the radiotherapy, by definition, is treating diseases, and in mostly malignant tumors. Not always. Sometimes we use radiotherapy for benign conditions as well, using ionizing radiation. This is important. We are using ionizing radiation. We are not using non-ionizing radiation. Treating patients with non-ionizing radiation is something else. Today, 1 out of every 2 cancer patients in the world requires radiotherapy at some point of their diseases. So it is basically half of the cancer patients requires radiotherapy. Radiotherapy do this. Radiotherapy do this effect by killing DNA. The most target. The radiotherapy kills hits the almost all tissues, all cell components, but its effect is mainly through DNA. There are several reasons for that. I don't want to go on this, but killing the DNA is good for cancer cells. If we kill the cancer cells, that's fine. That's what we want. But it's bad for healthy cells. Unfortunately, there are a lot of healthy cells inside or close to cancer tissues. So when the radiation hits to DNA, either it directly destroys the DNA, or there's an indirect effect through electrolysis of the water and other tissue particles. So there is a damage happens in the DNA. There should be single-strand breaks, there are double-strand breaks, bases, bases, all kind of damage can occur to DNA. Some of them can be repaired, some not. So in the end, if we are lucky, then we can kill all the cancer patients, DNA of the old cancer cells, so kill all the tumor cells. The success of radiotherapy depends on several elements, but the most important depends on the radiation dose delivered to the tumor. The higher the dose, the higher the tumor control. See, for example, in this graphic, if you can give higher dose for a prostate cancer, higher than 80 gray, your success is much better when you give a lower dose. The higher dose, the higher the tumor control. But unfortunately, the higher your dose, the higher your toxicity. The great Paracels of the Middle Ages said this, not for radiation, of course. There's no radiotherapy was unknown in those days. He gives this example quote as for the drugs. The dose makes the poison. Yes, the radiotherapy dose is the poison, and the higher it's a poison for tumor or for healthy tissues. The toxicity limits the prescribed dose. We want to give higher dose to all patients. 90 grade, 100 grade, but it's not possible. What we expect is this. Here you see it, that's the tumor, that's what we desire. 100, you get 100% dose to here and 0% dose to nearby structures. But unfortunately, that's not what we can get. Even with the best technology of today, that's the dose distribution we get. There's a very nice 100% dose here inside the tumor, but neighboring structures also get a good amount of radiation dose. And when you look at here, there are the tolerance doses of those tissues, 45, 54 for brainstem, optic nerves, 54, cochlea, vestibule, 50 gray. No more than these doses you should give. But the dose required to kill any cancer is higher than 70 to 80. So this means that without giving some injury or without giving some toxicity to nearby structures, it's almost impossible to kill all tumor cells. The goal of radiotherapy is basically to kill the tumor and to spare healthy cells while doing this. Since these normal tissues and tumor are side by side or even one inside of each other, it's almost impossible or very difficult to get this. What we want is, like the semi-signer of the billiard championship of Turkey, is to hit the balls and while doing this to spare the glasses. So this is a very, very difficult task. So, and all current radiotherapy research today is to reach this target, to give minimum toxicity while killing all the tumor. Our story started almost immediately after the discovery of X-rays by Wilhelm Conrad Röntgen in 1895. And also the next year, the discovery of radioactivity. The radiotherapy is benefited both of these great discoveries. Yeah. The next year, almost 1 year after the invention, the first use of X-rays for, let's say, the diagnostics, the therapeutic use started, not for a cancer. Leopold Freund in Austria described a patient where he gave radiation to treat nevi, pigmentous nevi, it's not a tumor. And the patient survived many years afterwards. You see the late effects here, almost when it's a small child when he was irradiated. And this is 75 years later. Patient survived good enough. And that's the result. It's gone. It's gone. It's an ulcer started here and it's healed by the time. But this is the first patient, just 1 year after the invention, discovery of X-rays. And the first use also the same year. The first years to treat a cancer, it was in France by Victor Depeigne. So this shows that the start of radiotherapy is almost the start of the radiation for diagnostics. It goes hand in hand. In 2 years later, we saw the discovery of radium and the start of brachytherapy by Marie Curie. The beginnings of radiotherapy, there were no collimation, no dosimetry, no protection. Of course, the effects of radiation was unknown, and our technology was very weak to provide these preventive measures. So patients were sitting on a table or lying down on the table or sitting on a chair, and there was very simple collimation and very weak protection of the healthy tissues. But what happened through the decades? Radiotherapy came a long way. The machines are changed considerably in 100 years. And today, the radiotherapy is completely different and safe method of giving radiation. The megavoltage machines, starting after the invented after the Second War, had a great contribution and changed all the face of the radiotherapy when you compare it in the first 50 years. Because in the first 50 years, we could have been using X-rays, and only we were treating superficial tumors. We are not able to irradiate the tumors deep in the body. But with the megavoltage treatment equipment, give us possibility to irradiate deep-seated large tumors. The first one was Betatron. This was used. This was invented in the 1940s to use accelerated electrodes to treat cancer cells. And then come the famous cobalt machines developed in Canada, simultaneously in 2 cities, and it was started to be used in 1950s, and these were advertised as cancer bomb and atomic bomb to treat cancer and to save lives. And with this cobalt, we were now able to treat very deep-seated tumors. We are able to give radiotherapy from different angles, so we can focus the dose to the tumor, and we could have been saving the nearby tissues more and more. Until 90s, this was the age of cobalts. Cobalts, when all developed cancer centers were using cobalts, and we were all irradiating patients with cobalts. However, starting from 1980s, the Linacs become more widespread. They become much cheaper. When they become more technologically developed, they quickly replaced cobalts. And why Linacs beat cobalts? There are several reasons. Because the first one, there was small penumbra of the Linacs, so they were providing better dose distribution. Second, Linacs said you can use with Linacs various energies, better skin sparing effects, and deeper penetration. So there you see there were a lot of advantages over cobalts. But another important factor was cobalts are using very high activity radioactive sources. And then there is always a radiation risk. And starting from the 11th September, also there was afraid of terrorism. So this high energy sources become very unpopular after those days. And also the increasing transport costs caused a very rapid decline of the cobalts against linear accelerators. Then come when we were thinking that the Linacs are the standard today, we saw starting from 2000 and increase of the number of the particle radiotherapy accelerators, because the particle radiotherapy accelerators provide better dose distribution when we use it with protons. And you see when you compare with the photons of today, it can be delivered by linear accelerators. When you compare protons here, protons definitely has a very much better dose distribution. However, these proton machines are not easy to use and easy to buy or easy to construct, let's say, because these are the biggest medical devices ever. you see this schematic view of a proton machine. There is a cyclotron, then the beam traverse here. That's the patient. When you compare the size of the machine and the patient, you can imagine that these machines are not easy to handle down. However, the proton machines are now becoming more widespread. The machines are getting smaller every day, and they're getting cheaper. There is no proton therapy center in Turkey yet, but I'm sure there will be even more than one centers in the near future. Protons are not the only particles that we can use for radiotherapy. There are also other heavy particles, which has dose distribution advantage and also biological advantages. When you compare here, the cobalt, X-rays, and the electrons, and proton is here. There is no radiobiological advantage of protons, but it's a better dose distribution advantage. But you see here, there are some neutrons, there are some fast proton, heavy particles. That also has radiobiological advantage as well. Also here, the boron neutron capture therapy, which is another story. And perhaps in the future, I think in the close future, we start using protons as standard, but then it will be replaced by other heavy particles in the future. So because that's the DNA damage caused by different types of radiations, the carbons has first better dose distribution and also more damage to DNA. When you see this damage to X-rays by damage to DNA by X-rays that we use today, it's a sustainable damage, you see, but it can be repaired. But if a damage occurs through a carbon ion beam, it cannot be, definitely. The cell definitely cannot repair this DNA damage. So it is more radiobiologically active. So what's coming next? The betatrons are eaten by cobalts, cobalts are eaten by Linacs, and protons are coming, and perhaps then heavy particles will follow very soon. Through these ages, we always wanted to shape the dose distribution around the tumor. So this is the 1D, 2-dimensional, 3-dimensional. That's the standard of today. So the rest is the healthy tissues. When we start this business, we were just drawing the contours. There was no contours even. We were drawing the shape of our field on the patient, on the X-rays, then or on the CT. When the CT arrived, okay, then soft tissues were visible, and then we started 3D volumetric planning. The CT revolution, we all witnessed this. CT evolution arrived first in the diagnostics, then it arrived to radiotherapy as well. Now, starting from 80s, we were able to reconstruct the body using CT slices. We were able to also develop the beam side wave images to better understanding of the radiotherapy and the tumor imagination. So you see that's what we are doing today. We can reconstruct the body. We can mark the target, we can contour, we can put our beams, and we can see our dose distribution in 2D and also here in 3D. We can remove we can put all the healthy organs, we can remove them, we can see them, and we can do this for individual patients. So to do this, also we need some extra tools. We need a CT, which is dedicated for radiotherapy, which is developed by the needs of the radiotherapy. This is called CT simulator. CT simulator is something more, equipment which is more than a diagnostic CT. This was started in 1990s. The differences between a CT simulator and the diagnostic CT is this. We have our machines are some CT simulator has external lasers, for better marking of the isocenter inside on the patient. It has a wide gantry aperture because in the diagnostic CT, patients are almost lying flat, and very rarely they go under the gantry within a different position. But in radiotherapy, we are using different positions, legs up, arms up, and various using slant boards, for example. So we need a wider gantry aperture. And also we need a flat tabletop, unlike diagnostic CT, because our machines, treatment machines, and the patients are lying in the flat tabletop. So it should be same. So this is CT simulator. Also, there are some softwares to mark the patients and to do some extra jobs. Then the invention of the software and the computers, and we started using computerized treatment planning system, which are very, very sophisticated and allowing us better dose distribution around the tumor and evaluating planning, contouring, and evaluation of the dose distribution and our plan. When intensity modulated radiotherapy was developed, this was definitely the zenith of the software technology, not only in radiation oncology but all in medicine. Because with the using of the intensity modulated, we were able to provide a non-homogeneous dose distribution, and it was able to develop inverse planning, so it was able to develop much better dose distribution around the tumor. You'll see, previously it was classically, that's the tumor that we irradiate, that's the dose distribution around. But with the IMRT now, it was possible to limit the dose around the tumor, so you can spare the many organs, this includes the parotid glands, which is very susceptible to radiotherapy. Also, you can see here, you can protect the medulla spinalis. You are able to protect the pons and other organs from the toxicity of radiotherapy, which is with the IMRT. And IMRT quickly became the standard of treatment. During these times, we always try to keep the patient stable during treatment. You see here, this is the first patient treated with a linear accelerator. The first patient, 2-year-old boy with retinoblastoma. You see, there's no stabilization. Patient is sitting on the table, and during the treatment, the doctors were saying, please keep quiet and keep without moving. It's good that the patient did not fall off the table even during this time. But now everything has changed. We are using a lot of equipment for stabilization. This is only for head. They have a lot of equipment for stabilizing other parts of the body as well. So when we come here, we are able to prevent the movements of the patients within a 1 millimeter. But even we keep the patient stable within the 1 millimeter, we cannot prevent the movement of the internal organs. The patient should breathe and the respiratory movements. Also, the heart is beating, the intestines are moving. We cannot prevent their movements, but we can control our radiation to give radiation according to these movements. This is done by 4D CT, 4-dimensional CT, and 4-dimensional treatment planning. We are using respiratory gating techniques. We are using deformative registration. And every day, a new tool is developed to control motion of the internal organs. So when you do standard CT of the patient, and when you reconstruct, sometimes you see if this is a tumor, you get this result. But when you harmonize this with the respiratory movements, then that's the CT that you get. This is becoming standard, and this is present in many radiotherapy centers today. So in this case, without gating, without 4D CT, that's the tumor you will get. But the same tumor with the gating, which is synchronized with so each slice is taken during experience, for example. Each slice taken during experience, not through the whole cycle, then that's the tumor you get. Through this time also we developed the gamma knife radiosurgery machines, and new equipment, also developed the robotic radiosurgery, and also you see with the robotic radiosurgery, this is another age. We are irradiating patients with the robotic coach, which is providing X-rays through here, and we see we control the positioning through X-ray sources and cameras, infrared cameras, and patient skin surface scanning techniques, and so on. And then also these two were gamma knife and cyber knife, robotic radiosurgery. These were dedicated machines, but quickly all the new linear accelerators. If I can move the next slide. Okay, all the linear accelerators had these systems, and our newest toy, let's say, is the MR-assisted LINAC, because the MR is an excellent solution for soft tissue imaging. So when you merge a linear accelerator and with an MR, you can see where you are irradiating during the treatment. Also, you can control, you can better see, visualize the soft tissues, and you can adapt your treatment every day, perhaps. So this is MR-assisted LINAC is developing. Until now, all I talked was about the external irradiation, but we also developed brachytherapy applications as well. When brachytherapy is irradiation with radioactive sources, which is put on the body or inside the body, or on the tumor or inside the tumor. Early days, it was manual handling of radioactive sources. So there you see there is again no radiation protection here. And when radium was invented, then started a radium madness. Radium was used for almost everything. It was for aphrodisiac, it was for beauty, it was in the cheesy, it was in the butter. This, you see, is a radium spa. It was used for everything. This was a disaster. But when the effects of the radium was understood, then we start develop machines to prevent exposure to patient and also to radiotherapy staff. Now we are using remote afterloading systems with miniature sources. We never getting radiation. We are not getting radiation anymore. Today, we have for brachytherapy better protection of healthy tissues. However, it's not used so frequently today. The reason is that these are invasive applications. It requires expertise. It requires expensive sources and also radiation protection requirements. But despite this, in many cases, brachytherapy provides better dose distribution than external radiotherapy machines, and it requires very strict quality control measures. The transport and disposal of radiotherapy sources used in brachytherapy is regulated and strictly controlled. There is always an emergency preparedness is required. This is not also required for brachytherapy, but for all radiotherapy. Quality assurance in radiotherapy is extremely strict. That's what I can say. And I know the radiology, I know the nuclear medicine, but the dose in radiation oncology, the radiotherapy is very, very high. So we should be extremely strict to prevent any toxicity, any disaster, and any accident. The quality assurance QA is an integral part of the radiotherapy process, and all members of the radiotherapy team is a part of it. Because when a radiation accident in radiotherapy occurs, not a single patient is affected. Multiple patients and multiple staff can be affected, and there are some very bad examples of these occurred during the past. There is always, for example, in when you are doing a brachytherapy, there can be always improper calibration of source activity. Source may stuck inside the patients, inside the machine. That you may use a improper identification, a wrong source due to improper identification. If there is an inadequate QA, then accidents may happen, and so on. We should be ready for that, and we should be prepared in case of an emergency, which involves all team members of radiotherapy. So, what's in the pipeline? What will we see in the future? That's my estimates, of course, not all of them, but so we are seeing emerging technologies, flash radiotherapy, artificial intelligence is coming, big data use. These are very, very popular today. The cloud-based solutions, the telemedicine is already there. So we are seeing patients. We can see the patients through telemedicine. Treatment planning, plan evaluation. These are all done by computers. So no need to do this in the radiotherapy department. This can be done from outside, from sitting in your home or another center. These are coming. Inexpensive technologies. So the protons and heavy particles, they are very, very, very extremely expensive now. But as I told before, these machines are becoming widely available. Their prices are going down and down every day. And the future, I think protons will replace today's linear accelerators in the near future, I think. And then comes the individual treatments. We are using more and more biomarkers, and we are using immunotherapy, chemotherapy combination, and these will be the feature of the radiotherapy. So there is always a continuous evolution. The radiotherapy has changed a lot when we compare the start and today, and even the start of my residency in 90s. There's a very, very much big differences, and this is a continuous evolution is continuing. But something is not changing. That's the radiotherapy team. There's a need. There's a teamwork, and teamwork brings success. This remains same. Radiotherapy is performed by a team of experts who should work harmoniously together and participate in several steps of the radiotherapy process. Radiation oncologist, medical physicist, dosimetrist, RTT, nurse, social worker, and so on. This brings the success, not a single work of a radiation oncologist and a medical physicist. This should be a team. This radiotherapy is a team effort. And lastly, if that's my quote, everybody has a quote, and that's my quote. If you ask me what is radiotherapy, I can tell that radiotherapy is a sophisticated art of medicine, which is exact to hit a bouncing ball in the next room with an invisible light emitted from a flashlight torch with an error of few millimeters, and to do this without hitting the other bouncing balls in the room. That's basically what we are doing when we give radiotherapy to kill the tumor and protect the healthy tissues. I thank you very much for your attention.
Thank you also, dear Yavuz, for this excellent presentation. You didn't forget anything at all. So I think there is nothing to contribute. And our time is over. So, and I think there is no questions. I'm obliged to close this session here. And I would like to thank to all of the speakers for their presentations. It was a very nice session, and I hope many people had good information about their questions. So we will meet in the other session in 10 minutes. Thank you very much to everybody.
Hayalperestlerin, risk alanların, denemekten korkmayanların cesaretinden doğduk. Bizi asla yarı yolda bırakmayan o sesin rehberliğiyle ilerlemeye ve öğrenmeye devam ediyoruz. Bunun için varız. Bu yüzden gece geç saatlere kadar lambalarımız sönmez. Elveda demek hem hüzün hem de gurur verir. Her şeyi sorgulayarak ve merakımızı besleyerek, dayanıklılığımızı test ederek, sınırlarımızı aşarak, ilerleyerek ve yeni ufuklar açarak yeni bir yol buluruz. Yeni icatlar çıkararak, kendi yolumuzu çizerek. Burası fikirlerin doğduğu ve yeni fikirleri doğurduğu, bizim de doğduğumuz, birlikte büyüdüğümüz ve yükseldiğimiz yer. Burası Yakın Doğu Üniversitesi.